a bit of interference. So thank you for all of those who are on your line and muted like asked. We will go ahead and get started as we are already running behind. It is my pleasure to introduce our two speakers today. Our first is Dr. Adelgais. She is an Associate Professor of Pediatrics at the University of Colorado, School of Medicine and Pediatric Emergency Medicine Physician at Children's Hospital Colorado in Aurora, Colorado. She serves as the Principal Investigator and Program Director for the Colorado EMS for Children State Partnership Program, as the past Chair of the Pediatrics Committee for National Association of EMS Physicians, and previously represented the American Academy of Pediatrics on the Board of Directors for Committee on the Accreditation of EMS Programs. She also serves as the Scientific Advisor for the Aurora Fire Department EMS affiliate role in PEM Node within the Pediatric Emergency Care Applied Research Network, or PCARM. Our second presenter today is Dr. Lindberg. He is an Associate Professor in the Department of Emergency Medicine and the Kempe Center for the Prevention and Treatment of Child Abuse and Neglect at the University of Colorado School of Medicine. He is the principal investigator of two of the largest prospective studies to determine optimal occult injury testing strategies to improve early recognition of child physical abuse. That being said, I will hand this over to Dr. Lindberg and appreciate both of their time in giving us to the webinar today. Thank you very much.
Thanks for the introduction. I'm going to go ahead and get us started.
Department at Northwestern Medicine, Kishwaukee Hospital. Please leave me a message and I will return your call.
Record your message at the tone. When you are finished, hang up or press pound for more options.
I'm so sorry for this.
No
our presenters.
We did get a long message on this. So anyway, as everyone I think knows, April is Child Abuse Prevention Month, and we're going to split this up. I'm going to give a little background, and then Dr. Adelgais will talk a little bit about a tool to improve providers' ability to recognize early signs of child abuse, and then I'll bring it home with a further discussion of universal screening. And so we're really going to split it up into those two sections, recognizing early minor abusive injuries, and then talking about universal screening programs in emergency departments. I don't think I have to convince anyone on the call that abuse is a big deal. I probably don't have to convince anyone on the call that it's a bigger deal than they think even, but the numbers are out there that about 3 million children are reported to CPS each year with concerns of maltreatment, and about 2,000 children die from maltreatment, either physical abuse or neglect, each year. Those numbers, I just want to encourage people to think about maltreatment as more than the number of injuries and the number of fatalities, because some of the best evidence we have in the maltreatment world is that abuse is much more significant than the injury that's in front of you. So the two concepts I want people to think about, still up here in a couple different conversations in the background, but the two things I want people to think about is that whenever you see abuse in one child, that's a whole household that's probably dealing with family violence, and that's a chance to recognize things like intimate partner violence or elder abuse, and is probably a bigger problem than just one kid. The other thing is that it's a bigger problem than just a single injury, and this is that acute adverse childhood experiences research that most people have probably heard about, that witnessing abuse or witnessing intimate partner violence carries long-term health problems beyond the injury itself. So a bruise may not seem like a big deal, but maltreatment has been associated with increased rates of COPD and heart disease, diabetes, sexually transmitted infections, early death. And so it's a bigger problem than just the given injury. So what we're here to talk about is early recognition of abuse. In my experience, I think abuse seems different than all the other diseases that we try and pick up on. In the general emergency department, we're always trying to pick up acute coronary syndrome. Sometimes it's subtle, sometimes it's hard to see. But we have algorithms for this, and it's not such an emotional burden to find acute coronary syndrome or subtle things that happen in trauma compared to abuse. And, you know, when I talk to people, sometimes providers can seem really uncomfortable finding abuse. And I personally think we can make some progress by trying to think about abuse in the same way we think about all these other diseases we have to pick up on. There's lots of evidence that many abuse cases come to the emergency department for the first time with relatively minor injuries. Things that if we pick up on the abuse when they first present, things can have a pretty good outcome. But if we miss it, kids can return with very severe outcomes like abusive head trauma, where injuries are permanent. So what we're going to talk about today are two different ways to pick up on these injuries when they're relatively minor, and where we can intervene to protect these kids before you have a serious or permanent injury. And so let me introduce the idea of the sentinel injury. Most people have probably heard about this, and there's some controversy about the final definition of a sentinel injury. But today, what we mean by a sentinel injury is a relatively minor injury that can be seen on a child and raises a significant concern for abuse. And the two biggest studies that have looked at this, the most cited one is probably by Lynn Sheets, who looked backwards at a few hundred kids who had had an abuse consult. And she found that kids who were ultimately found to be abused, about 30% of them had had a sentinel injury, like a bruise, an oral injury, or a subconjunctival hemorrhage, that may or may not be noticed by the providers, but may have been noticed by a caregiver, which was an opportunity to pick up on the abuse earlier. My group looked at this in a different direction. We looked at the FIS database and used ICD-9 codes, which have their own limitations, but looked at kids who had bruising or oral injuries or any other kinds of injuries that seem like sentinel injuries, and looked at the rates of abuse. And as you can see, for the youngest kids, rates of abuse were in the high single digits to low double digits, certainly enough to make us test for abuse or think about abuse every time when we see this. So with that definition of sentinel injury, I'm going to turn it over to Kathleen to talk about her tool to improve providers' ability to recognize these sentinel injuries in young kids. Kathleen, you may be muted if you're talking.
Everyone hear me okay?
We can hear you, but you're very light.
Now can you hear me?
No, you're very, very quiet.
Dr. Adelgais?
Maybe if she could go to somebody else's speaker who's trying to mute it but can't.
Yeah.
I know, I'm trying to get on.
While we have this natural pause, that's why it's recommended for you to use your phone audio for these webinars.
Can you guys hear me okay?
Yes, we can. Thank you very much.
All right. Sorry, I was trying to be on the computer, but it wasn't working. Thank you guys. Apologize for another technical delay. And thank you, Dan, for those introductions. You can advance the slide, Dan. So when we talk about cutaneous injury, which are the sentinel injuries that Dan just covered and why they're important, there are some general themes. The first theme is age. So there are certain bruises that shouldn't be occurring on younger children who are not necessarily mobile. And we'll cover a little bit more of that. Another common theme is location, and the location of the bruise may also be a sign of what may be either abusive or accidental in nature. And then the third theme is typically the overall pattern of abuse or pattern of the bruise that you see. That can often give you a sign of whether something could have occurred accidentally or not. One example is bruises that are multiplanar, so they go around multiple planes of an extremity, typically are from being grabbed. Next line, Dan. So well, let's talk a little bit about age. What's most important to take away is that bruises in the very young are uncommon. And this was a study done almost about 20 years ago now by Naomi Sugar out of her Well Child Clinic in Seattle, Washington. And she quantified bruising on young children at Well Child visits, almost 1,000 children, and found that those less than 6 months, out of almost 1,000 children, only 2 had any bruises, and they were both scalp bruises. And then those less than 9 months, about 2%, or a total of 8, had bruising. As you can see from that bar graph, these are very small numbers compared to those who are cruising and walking, where the rates then go up to about 18 to 52%. And it coined the term, those that don't cruise don't bruise. And that is a really nice way to kind of remember when you should be seeing bruising in certain age groups. Next slide. With regard to location, I found this image. A friend of mine gave a similar talk and had this picture, and I just thought it was so useful, and so I put it on here. You can see where bruising occurs on the body and how that is more consistent with abuse versus not, and you can think about the mechanisms about what you would typically see. So if you look at the face there and at the right and the left cheek, interestingly, the left cheek is 5 times more likely to be related to abusive injury than not. And if you think about the fact that most people are right-handed, when they're facing a child and they slap the child's left cheek is what's getting hurt. And that's also true of the ear, which is 7 times more likely, a bruise on the ear, to be related to abuse than an accidental injury. Upper arms, front thighs, buttocks, these are all soft padded areas without bony prominences and less likely to be abusive or less likely to be accidental in nature. And the other interesting thing, if you think about both the ear and the neck, these areas are relatively protected by the large cranium and the shoulder. And so in order to get accidentally injured there are not that many mechanisms that cause a bruise in those locations, which is why they are more likely to be abusive in nature. Next slide. So this brings us to the 10-4 Faces bruising rule, which is a validated bruising rule that helps identify and raise concern about sentinel injury findings in inflicted children. So this relates to any bruising on the torso, any bruising on the ear, any bruising on the neck, or on the face. And then also this brings in age. 4 in the 10-4 Faces rule stands for children less than 4 months. So again, the non-mobile child and bruising in those high-risk areas. When applied, this rule has about 97% sensitivity. In other words, the true positive rate of bruises is about 97% in correctly identifying abuse, and about 84%, or the true negative rate, in identifying accidental injury. In other words, the absence of bruises in those locations is 84% likely that it's related to an accident as opposed to an abusive injury. Next slide. So the FACES stands for face, but it also has a nice acronym for specific findings on the face. F stands for frenulum. Frenulum tears are pathognomonic. A stands for auricular, which is the ear. C and E stand for cheek and eyelid. And then finally, S stands for sclera. So these kinds of injuries are all concerning for abusive injury, and you can use that mnemonic to help also track where the facial injuries are that are more concerning for accidental. Notice that F does not stand for forehead, because forehead bruising is usually very commonly accidental in nature, as kids can fall forward, and that's a very prominent bony area. Next slide. And this is a nice atlas of the 10-4 faces. So the far left of the screen is the abdomen or the torso. You also see eyelid bruising. On the far right upper corner of the screen, you see a bruise on the neck or under the chin. You see a bruise on the ear. You see a bruise on the arm. And again, these are examples not only of bruises in the key locations, but in a very young infant, a child who's not mobile. And this is all of the images that I'm showing you here are actual cases of patients that we're seeing at Children's Hospital Colorado. And so this is the kind of findings that we do see in abusive injury. Now, if the medical provider is evaluating the child and sees a funky bruise somewhere, you have to ask why on earth would a bruise happen in that location. From a mechanism standpoint, you can imagine the bruise under the chin in the far right corner is really from grabbing the child by the chin and typically force feeding. And that's also a mechanism commonly seen with those frenulum tears. The spoon or the nipple of the bottle gets forced into the mouth and often will slide up along the gum and accidentally tear the frenulum. So that's why those kinds of injuries are always very concerning for abuse. Next slide, Dan. Let's talk a little bit about burns. Burns are another form of cutaneous injury that can be accidental or can be related to abuse. Most accidental burns often have splash marks or flow lines of the pattern of a scald, and these are classic pictures here of where those occur. They tend to kind of follow down along a leg or extremity, or often on the front torso of the child, typically when they're pulling something hot off of a counter, a bowl of soup or a cup of tea, and it splashes onto their chest wall. The other key thing that you see there are how the layers of the burn are multi-layered. In other words, they're not all a single type of burn. This fits with that flow diagram or flow method or splash that occurs. Now, that's in contrast to these burns, which are, to be honest, are very hard to look at. But what you see typically in burns of abuse are very sharp lines of demarcation, typically from immersion injuries where an extremity is immersed in boiling hot water or as a cause of punishment. The hand in the lower right screen is another example, and you can see a very sharp line of demarcation extending up along the forearm. The other key thing, if you look at the feet and the hand, are that the whole hand, the whole foot is equally burned, and that's much more common than if something were to splash or hit them accidentally. Cigarette burns are a classic example of burns with a sharply demarcated edge in a pattern, and then mouth burns, again, are if somebody is trying to force feed the child maybe something that's too hot and the mouth gets burned. So given that pattern of burns and bruises, we know there can be accidental ones. We know there can be, abusive ones. Really being able to distinguish between the two is important, and being trained on how to identify these differences is what we sought to do. Next slide. So this is just to kind of understand what the need for training on this is. I think sometimes we think we know it when we see it and it's intuitive, but it's a high-risk, high-stakes situation. Being wrong and accusing somebody of abuse when it wasn't, or thinking something's abusive when it wasn't, is very intimidating. And on the reverse end, missing it has very serious consequences. And all states have mandated reporters. Mandated reporters are those that are they're mandated to report if they suspect abuse. They're typically whistleblower protective laws to protect people from being wrong. But most mandated reporters, if you survey them, feel very unqualified to actually make a report, and they often report a lack of training to be able to make a report or be able to distinguish it adequately. And so the problem ultimately is that mandated reporters without good training and tools will basically still lead to under-recognition and under-reporting. Next slide. So we had a research question. It was, could we develop training and education to establish, competency levels and improve self-efficacy, that confidence that you can do something when distinguishing between abusive and accidental injury from medical providers. The competency level is also key. People then undergoing training and getting feedback on that they are, quote, competent will also kind of work to make them feel that they're adequately trained to be able to make those mandated reports as necessary. So among the world of medical education, there is a concept called deliberate practice, which is where somebody practices a skill, gets real-time directed feedback at the time they practice the skill, and then gets an opportunity to practice it again. And in the case of our training, we basically wanted them to practice the skill of distinguishing between abusive and accidental injury. And we were analyzing the learner's responses on whether something was abusive or accidental against a gold standard. Educators can use deliberate practice and this methodology to create education, maximizing the ability to distinguish between what's normal and abnormal. And in our case, we're really talking about what is abuse versus an accident. Next slide, Dan. Using this kind of theory, there's actually a component of what we call signal detection theory to help identify whether a learner is accurately starting to learn the difference between abuse and accident. And so this 2x2 table kind of shows what that signal detection theory looks like. Signal detection theory allows a gold standard to be mapped against an individual's indication of yes or no. In our case, yes or no is abuse or accident, and our prior determination is from child abuse experts whether something was abusive or an accident. In the case where the learner identifies an abusive injury when it's actually abuse, that's considered a true positive, and the same for accidents. If it's an accident and the learner also thinks it's an accident, that's considered a true negative. In the case where the learner identifies something as accidental when it's actually abuse, that's a miss. And in the reverse, when the learner assumes that something is abusive when it was actually accidental, that's considered a false alarm. And by kind of quantifying or categorizing these different responses in this way, it allows us to track both a sensitivity, accurately identifying abuse, and a specificity, accidentally identifying accidental injury, and then overall accuracy, how correct is a learner over time. And the term terminal on the slide is referring to, as people have moved through the series of cases, at the end of doing the module, this is the terminal knowledge that they've acquired. Next slide. So our objective was to create this educational module using deliberate practice to train medical providers distinguishing between abuse and accidental injury in children. You can see all of the different institutions at the bottom of the slide that were involved in this work. Next slide. What we did is we created a case bank from real patients seen at Children's Hospital Colorado and Denver Health Medical Center with cutaneous injury. We actually selected, in our case mix, 60% would be abusive by gold standard and 40% would be accidental. And the reason for this is that when you mix the proportion of abnormals to normals, you can drive learners to a certain outcome. And we wanted that because we felt like the risk of missing abuse was higher than the risk of missing an accidental injury. We acquired about 200 cases. We refined our group to 114, 68 cases of bruising, and 46 cases of burns. The electronic module was created with vignettes and images, and the learner then submitted an answer regarding the need to notify social services based on what they were looking at. Next slide. This shows what that looks like when you go online to the website and register and you start your cases. You'll get the initial image to the left, the module. At the top, there's a case bar that shows how you've progressed across. The case has a title. In this case, it's vomiting. I know the print is small. There's a clinical vignette to read. And then the last question is, as a mandated reporter, would you report this injury to social services, yes or no? The learner, as they go through the module, can click on the actual image, and to the right you can see it'll enlarge the image to the full size of the screen so that somebody can actually take a better look, and then you can go through the series of images. Once the learner is identified whether they would or would not report to social services, they hit submit. Next slide. And then they get an immediate feedback response. In this case, the learner said yes, they thought it was related to abusive injury. The feedback responses you get, those said, ding, 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 yes, you're correct, woohoo. But it also provides those text and visual feedback with arrows and other things to kind of help identify or help the learner learn why they're correct. The learners are informed of whether they're correct and incorrect, because sometimes you do a test online and you get an answer right and you don't know why you got it right, then you're not really learning from that. So our goal was to provide feedback with each case that the learner went through. And as they sequentially went across, they would start to acquire more knowledge of things to look for and to recognize. Next slide. This is a case example, a 14-month-old female with her grandmother while her mother was working. When the mom came home, she found the child with these injuries, and the grandmother told her that she heard the child fall down some stairs but didn't witness the fall. So in this case, the learner would see these pictures, read that clinical vignette, and hit yes or no. They are concerned about what they're seeing, and they would indicate whether social services would be involved. Next slide. And this is the feedback that they automatically get. They get a description of the type of injury, bruising in a young toddler. They get some additional information. Is the history consistent with the injury? And no, and why? So the facial bruising could be accidental, but what you do see are certain lines that are a sign of being slapped on the face. In addition, the bruising on the arm is more consistent with a grab mark, as it's multiplanar and kind of wraps around the soft part of the arm and is not on a bony surface. So that's how we can tell that this is likely abusive in nature, and that's the feedback and training that the learner doing the module gets. Next slide. So these are some of our findings to date. We launched this module in December 2016. To date, we've had a total of 750 users. Some of you on the call may be familiar with the module. It's actually been approved for EMS education in 10 states by the state offices of EMS. We've analyzed data on 271 EMS providers. We've analyzed the learning curves. We've done some item analysis and also some self-efficacy analysis as well. The demographics of our users to date or of the 271 that we've analyzed are shown there. The majority of them are male with a median age of about 40. About 50% of the learners that we've analyzed were EMT basics, about 33% paramedics, and about 11% physicians, and this smattering of other kinds of providers. The median years in practice are 12. About 20% have actually made a prior report to CPS. Given the predominance of EMS providers in our data sample, that's not surprising. And we did find that about 48% had actually reports making a prior report for child abuse, or having had prior training on child abuse and neglect. Next slide. And these are our learning metrics. I do want to thank Martin Cusick and NYU, who gave me this data last night. And so what we see here is that the terminal accuracy, overall, how accurate are the learners at the end of doing the 114 cases, about 83%. The same with both sensitivity and specificity. And to the right of the screen, you see some of those learning curves. Obviously, the learning curves look fairly straight. The EMS providers in general and the physicians all have, you can tell, are actually the very same rate of learning across the module, that with each successive case, there is a slight incremental increase in the probability of getting the next answer correct. And I think that that's really important. We also see here is that where you start kind of determines where you finish, given that the rate of learning overall improves kind of along the same line. It's not surprising that in comparing different provider types, the physicians are a little bit more likely to be accurate with each successive case compared to the paramedics and compared to the EMT basics, but with the EMT basics being the reference. Overall, though, again, the learning does improve across all groups. The other key thing that we found was that if you were looking at a case of a burn versus a bruise, you were more likely to be correct identifying abuse among those that are bruising patterns. And I don't think that this is too surprising given the focus and the training on the 10-4 faces rule that we put into the module. Next, and the other, go back 1 second, Dan. Thank you. So the one key thing that we did find, which I was quite surprised by, was that our biggest gains were actually in recognizing accidental injury. I think that part of this was we heightened the sensitivity for abusive injury as you go through case after case after case. But the other, I think, real big bang for our buck is that we improved correct recognition of accidental injury. In other words, that I think does help people feel more confident that they're not going to inappropriately find an injury and automatically suspect that it's abuse. So I think that there were some real benefits of providing this training that improves the recognition in both ways. Thank you, Dan. Next slide. We also did some self-efficacy analysis. And that was using a retrospective pre-post study. So the primary question was, as compared to before I participated in the module, the learner then could indicate that they were more comfortable performing a medical exam with bruising, or more aware of which circumstances require a report to Child Protective Services. Next slide. And these are our self-efficacy results. Across the board, you can see that all of the learners either felt moderately or strongly agreed with that statement, that they were more confident in knowing when to report CPS, in performing the exam. The one thing that we didn't really improve confidence in as greatly was in obtaining the history, but that wasn't really the focus of the training. So I think that adds some validity to what the training was good at and what we were not really kind of doing with the training. And the other key thing to notice is that the same confidence was as high for both performing the exam, interpreting an exam, performing an exam, interpreting an exam across bruises and burns. Next slide. So I'm going to hand it back to Dan, but I do want to provide some thanks to the large group of individuals and institutions that really worked hard to create the module and create the cases for the module. That is the website right there. As you can see in the little screenshot, the upper right-hand corner is a registration and login button. It's free. It will be moving to another location in the next year or so for sustainability, but right now it's available for any and all learners. And we'd love it if you are curious about it, go on and take a look. And at the same time, certainly encourage others to do it if they're looking for a way to get more training in this area. Thanks, Dan. I'll let you take over from here.
You know, I appreciate that. Since we're doing well on time, I wonder if we should pause here and see if anyone has any questions about this particular module before I change the subject radically. I did notice that one came up on the chat that I want to highlight. Tia asked, you know, isn't it a little early for people to be making a final conclusion about abuse? Shouldn't we, when we're mandated reporters, just say, this is a reasonable concern, I think this is a good point, you know, I think this is something that needs investigation, but not say this is abuse, is not abuse. And I thought that was a really good point. And I just wanted to emphasize that this module asks people, would you report or not? It doesn't have to make a final conclusion about abuse. It just says, is there a reasonable concern that would generate a report? And I thought that was something to emphasize. So I just wanted to see, since we seem to be doing okay on time, does anyone have any questions for Kathleen before I move on?
I should have told it, Cassidy, I talk fast, so don't worry about the late start.
Well, thank you. That's making my stress level go down quite a bit. Yeah, if there's any questions, please feel free to mute your line, or if you don't want to mute your line, go ahead and put it in the chat box. This is a great resource that Kathleen has highlighted, and it absolutely is definitely worthwhile your time if you have any questions about it.
Well, hearing none, I'm going to go ahead and move on to a different topic. So I think Kathleen's resource, like a couple people in the chat box are saying, is really useful, and I think it's great for a lot of different learner levels. I'm going to talk not about improving recognition of sentinel injuries, but about a different strategy that's getting a little attention these days called universal physical abuse screening. Now, this does not mean that every child who comes to the emergency department gets a forensic interview or a skeletal survey. This is basically the concept, though, that every kid who comes to an emergency department, someone has to think about abuse and at least ask themselves, is this concerning for abuse? And this comes, as we just talked about, that physical abuse is commonly missed, and it happens even at major centers like Children's Hospital Colorado. I want to make it clear, I think our center does pretty much a better job than anyone else in the world, or as well as many people on this call. But even in great centers like this, we still continue to miss abuse, and that sentinel injuries are one aspect of that care that Kathleen talked about, but that we're starting to see other centers using universal screening. And I would characterize the evidence behind this, which I'm going to talk about more in a few minutes, as B+. It's not fabulous. It's not something that would make someone do this if they didn't want to or if they were skeptical. But I do think that regulatory agencies, especially people who accredit pediatric trauma centers, are beginning to look at this and say that the evidence out there is enough to support this. So let's talk about the evidence. The whole concept of universal screening was started in the Netherlands by a group that developed what they called the ESCAPE tool. And I'm not sure, like a lot of tools in the Netherlands, I'm not sure what the acronym stands for. But you can see the tool in front of you. There were 6 questions, some of which come up in any tool. Is the history consistent? Was there a delay in seeking care? Is there a developmental level to the child? I'm going to skip a little bit and go to number 6, which is basically like, hey, are you concerned about abuse for some other reason that's not on this tool? And this basically gives the person, in the Netherlands it was the triage nurse, the chance to just pipe in with their own opinion. I'm also going to point to question 4, which is going to end up being a very controversial question because, as Kathleen alluded to, one concern with recognizing abuse is that sometimes it can seem so subjective that it invites us to recognize abuse more commonly in people who don't look like us or who are poor rather than wealthy. And a few different people have looked at number 4, is the behavior of the child or his or her caregivers in their interaction appropriate, and said that this seems like an invitation to bring in cultural judgments, but that's my own opinion. And then it asks you to do a head-to-toe examination on the child. And this was deployed in the Netherlands, first as part of a research project, and then as a law that every child who comes to the emergency department, and they defined a child as less than 18 years old, to get this tool. And so here's this data that I was talking about before. So they deployed this. They had about 40,000 visits to the emergency department. And even though it was mandated by law halfway through the study, the forms, these were paper forms, were really only completed a little less than half the time. And I think one of the most important data points that we want to point out is that the form was only listed as positive about 1% of the time. So if you're thinking, well, maybe should I deploy this or not? If I deploy this, am I going to get 100 more skeletal surveys a day because people are saying this is positive all the time? I think this data says probably not. That it's not. People aren't going to just willy-nilly check the box that they're concerned for abuse. And then I think the other data point that's important is that among people who did check the box and say, I'm concerned for abuse, about 10% of those were thought to ultimately be abused. Now, there were some kids that were thought to be abused where the form was not suspicious, but it was lower, especially given the number of forms where it was not suspicious. And 10% is an important number in 2 directions. The first is, that's a relatively high rate of abuse. I mean, if you say, look, would I do 10 skeletal surveys to find one abused kid? Most people, I think, would say yes. The other thing is, it's not 100%, okay? So when this form gets checked yes, I don't push people to pull a big lever on the wall that's associated with a giant light and a siren and call the cops right away. I think this is something that makes us think about abuse, makes us consider this carefully, but let's, take a deliberative approach on what to do. So that was the Netherlands experience. They concluded that, look, screening increases the rate of abuse detection because, the rates of abuse were so much higher in kids where they were screened than where they weren't. I think it's another interpretation is possible, which is that since the form was only used half the time, that you're probably less likely to use the form in a kid who has really, really, really low risk of abuse. But I think that's an open question and needs to be tested prospectively. So what about in the United States? Well, Pittsburgh did their own version of the escape tool. And it's very interesting when you read this paper. They said, well, we adapted this for use in the United States. And I think, this is a confidential call, right? It's not like it's posted. No. But it seems like they used the adaptation to really make some changes that I think are probably good changes, but which were just their expert opinion. It's an expert opinion I happen to agree with. The first is that they removed the idea of, is there an abnormal interaction? Is there something about the way that the child or the carers are interacting with people? And I think that was a good call. There's still plenty of room for people to put their additional concerns in number 5, but I'm glad they took that out. The second is they got more specific about what they're talking about on the head-to-toe physical examination. So they looked at that 10-4 faces rule, and they really put that in about non-mobile child. They did burns and bruises, subconjunctival hemorrhages, frenulum tears, where the bruises were, pattern injury. And so you can see they really added a lot more details to what they were looking for on the physical exam. And then the other thing they did was they just switched it so that yes was always the response for concern for abuse. In the original escape tool, sometimes no was concerning, sometimes yes was concerning. This was a version where they just, yes was always the concerning thing. They also made it an electronic thing, so it fired through their electronic health record, which was Cerner. And they characterized this as mandatory, but it wasn't a hard stop. It's not like they made you wait to order the epinephrine on a kid who is coding in order to do these screening tools. So what were their results? They deployed this in 13 emergency departments, including a huge, well-respected flagship hospital, Pittsburgh Children's, which I'm giving the wrong name the wrong branding name for their hospital, but Children's Hospital of Pittsburgh, and then 12 other sites in their network. So it wasn't just in an ivory tower. In that network, they had more than 17,000 kids that were eligible, and they defined kids as less than 13 years old. And the reason for that was before implementing this, they had a domestic violence screen for everybody. And they said, look, it doesn't make sense to screen a 12-year-old for domestic violence. It does make sense to screen a 13-year-old. So they said, we're going to have one question for everybody. Below 13, you're going to get screened for child abuse. Above 13, you're going to get screened for intimate partner violence. So like the results in the Netherlands, they didn't have 100% screening. They did a little better. They got to about 70% where they were screened. And only about 2% of their forms were positive for any concerns for abuse. Now again, in kids who were positive, the rates of CPS reports, which was their standard of a reasonable level of concern for abuse, were higher when you were positive. It was about 1.3% who got a CPS report when they were positive compared to 0.4% when they weren't. But I still think that leaves us an open question of, are you more likely to report because you're screening, or are you more likely to screen because you're concerned enough to report? So this shows, I think, that you can implement it, that it doesn't grind your emergency departments to a halt, that people accept this and think it's a reasonable thing. I think it also supports that you shouldn't start tying nooses just because the form is positive, and this is a reasonable thing to try. So our center looked at these data and said, this is probably something we should do. Some of our outlying centers had some missed cases and wanted to implement something like this, so they asked us to develop our own tool. And so we changed the tool a little bit. We did not want to have 6 click boxes in our electronic health record, and we wanted to include even more about what a sentinel injury was. So we brought it down to 2 questions with multiple parts. So it's You could say we added more questions. You could say it was fewer questions. It's fewer clicks, but it's a lot of information. So the first question is about the history, and it talks about, is it inconsistent? Was there a delay in seeking care? Is this an unwitnessed injury? And then it leaves that sort of wastebasket term, is there anything else that makes you concerned for abuse? Which in the Netherlands was their most accurate click box. That was the one that was most sensitive and specific given the limited data that they have. And then the second question talks about sentinel injuries. And we feel like there's enough training about 10-4 faces that we just use the acronym. Is there 10-4 faces bruising or bruising in a child less than 6 months old, or fractures in non-ambulatory child, or signs of head injury? And we listed some of the signs of head injury. And so our tool at our center is used in kids less than 6 years old, and it pops up as quote mandatory, but it's not a hard stop. It's done by the primary nurse at the same time that they do things like travel screening or intimate partner violence screening for older kids. And if it's positive, two things happen. First, the nurse is prompted to undress the child fully. And second, the provider gets a mandatory, this is a hard stop text box at disposition. And they have to put in a comment. The comment can just be like, see chart, or not worried, or stop bothering me. But the reason we had this mandatory pop-up box before you discharged or admitted a patient was so that you didn't see this documentation the next day when you were signing your charts and go, oh my goodness, someone else was concerned about abuse and I didn't do anything about it. Notably, this mandatory hard stop doesn't fire if you've done something that makes the computer think you're concerned for abuse, like order a skeletal survey, consult a child protection team, or consult a social worker. So that's the tool we built. We think it's relatively painless, and we think it'll help us catch the catchable case. But I want to end with my own assessment of this tool, using this diagram that we sometimes use when we're talking about when to make a change. We look at the effort involved and the potential payoff. If it's low effort and high payoff, you should do it right away. If it's low payoff and high effort, you probably shouldn't do it. And then if it's low effort and low payoff, or high effort and high payoff, you got to think about it. My own opinion is that adopting this tool fits somewhere in these bottom two boxes. I'm pretty convinced that it's a relatively low effort. Sure, it's a couple clicks that may be involved with 100,000 patients a year in a busy center, but it's really a couple clicks. We've been travel screening for Ebola for this many cases, for far few cases of Ebola. And I guess the question is the payoff. Do we feel like we're already catching all these cases, or do we think this is going to help us with some of the cases we continue to see? I feel like if it helps us with even a few cases, that's enough payoff for me. And so at this point, I think this is where I'm going to stop and see if people have questions or comments about this process.
Thank you, Dr. Lindberg. Definitely go ahead and submit those questions to that chat box. I'll be happy to relay those to the speakers. All right, so we do have a question from Dr. Arbach, and his question is, what has experience been for positive screens? Are they calling child abuse reporting?
It's a great question, and we don't know at our center because we're just starting to deploy this. At Pittsburgh, they have a little data having entered this into their electronic health record, and they basically showed that they were doing a great job before this, and they continue to do a great job after this, and it doesn't grind their emergency department to a halt. But they've got a little bit of a ceiling effect because they're already a high performer where they're studying it. What I recommend when this is positive is, so this is done by the nurse, and I recommend that the nurse go to the provider and say, I clicked this as positive, and this is why I'm concerned. And the provider should think carefully. Now, if I'm the provider, I've done a child abuse fellowship, I'm going to just run that case and see what's concerning and talk to the nurse and make sure we're on the same page. A lot of people out there haven't done child abuse fellowships. I think that's not going to change. And so I think that they can certainly call us. We've deployed this with some educational background about, what is a sentinel injury, what are some tests that you should do, and please feel free to call us. Ultimately, the response is going to be different in different places. It's going to be different at Children's Colorado with fellowship-trained people able to respond at a moment's notice, versus at Our Lady of the Faint Hope, who may see 2% kids and one child abuse case a year, and hopefully they'll be a little more thoughtful and careful in a rare circumstance than someone who sees abuse 10 times a week, and they might be a little more conservative and do more testing, but it's going to change for different providers.
Perfect. Thank you so much. And I believe the last two, I'll just rapid fire to Dr. Adelgais. It's in regards to the training modules. The first question was, at the end of the module, upon completion, do you get a certificate, and also a certificate of completion, and also is there consideration to create shorter versions for professionals in the EMS world who may only get an hour for training, because this question is from Tia. She actually took the training and she felt a little overwhelmed with the pictures and the timing. Is there plans for it, or is something like that already available?
Thanks. Those are great questions. With regards to the certificate, yes, there is a certificate that prints off. When the learner goes onto the website to do the module, they register, and by registering, they create a password that only they know, and an email address, and then at the same time, they also put in their first and last name and some brief demographic information. And the first and last name are used to go onto a certificate at the end, and then also we take the overall percentage of questions that are answered.
Whoever is talking to us, Sherry, please mute your line.
Among those that are, we take and actually put a score on the certificate as well, because some states require some score as proof that they've completed education and scored a satisfactory amount. And the score is based on the last 30 questions that they answered and the overall accuracy. So most people, as you could see from the data I showed, are getting a score of about 80% correct. And so if you are a state that is approved for this EMS education, we've uploaded those state EMS education certificates to our website. And if you indicate by your demographic data that you live in Alaska, then the Alaska State EMS CME certificate with your name and information and score is what prints up. If you are not one of the states where that's the case, then you get the Children's Hospital Colorado, which we're an approved EMS education center, you get that certificate. One of the reasons why we're moving the website eventually is because we have not been able to find an accrediting body to provide CME and CNE for nurses and physicians. And so it'll be moving to a group that will be able to provide those certificates, and we'll be maintaining the EMS education. As far as the question with regards to have we considered making it shorter? We haven't yet, because we've just finally done a lot of the analytics. We did do some item analysis where we looked to see how easy certain questions are, and we pulled out some of those questions to see is there a lot of learning potential from them? Could we remove some of them? And everybody who reviewed them felt like each case was too important. But I think of the questions that are, quote, too easy, where there's not a lot of learning from our learning analysis and our metrics that we've been studying, item analysis, I should say, we may be able to make a shorter version where we're keeping only the real bang for your buck questions in there. And that's a great suggestion. And I think if I can find a separate space for just EMS education alone, we can maybe make a shorter version of it and have it continue to live there for free. But for the CME and CNE, it will be going to another site. And I think the full body of questions will be there, and 2 hours of CME and CNE will be offered. That's a very long answer to 2 short questions. I'm sorry.
No, that is fantastic. Thank you, Dr. Adelgais. But we have reached the end of our scheduled time for the webinar. Apologies for anybody that was not able to hear the audio because of the massive amount of interference we were having and the timing. I had to quickly disable many things to try to get a pretty good start time so our speakers could have enough time to discuss their very important material. But the audio recording was available on the phone and has been recorded and will be placed on the EIC website. So again, apologies to my speakers for that. Just some limitations with technology occur, and I can do my best to mitigate, but that's all I could do at the time. So thank you for your patience, and like I said, this webinar will be made available on the EIC website, and we thank you all again for your time, and a big thank you to Dr. Lindberg and Dr. Adelgais for your expertise and knowledge that you provided to us today. All right, that being said, I will go ahead and end the call. The chat box will remain open if you want to submit some extra questions. Thank you so much.
Thank you.
Oldham County EMS, this is John. Hello, Maine. Chow Mein, Lo Mein.